So it's next my very pleasant task to introduce the talk for this evening, which is by Scientia Professor Richard Bryant. And Richard, well, is my colleague at the University of New South Wales, is Scientia Professor there. He's a commander of the Order of Australia, which is the top distinction in that in the Orders of Australia. And he's a fellow of 3 academies: Social Sciences, the Academy of Science, and the Health and Medical Sciences. And so he knows what he's talking about. He's advised the WHO on how to manage stress and so on. And so tonight he will talk to us about managing psychological distress in times of stress, handling the stress of COVID-19. Richard, the floor is yours. Thank you.
Hello, I'm Richard Bryant, and I'd like to start by sincerely thanking Dr. Pond and the Society for giving me the James Cook Medal this year. It's a great honour. When I look at the people that have won the medal in previous years, I feel very humbled to receive this medal. I know it's not given out lightly. And I'm particularly sorry that I can't be meeting with everybody in person because of the pandemic. And I'm also sorry that this is actually a pre-recording because I'm unfortunately double booked on the evening of the normal session. So a few apologies, but underpinning that, heartfelt appreciation for the medal. And as part of receiving the medal, I do get to provide a talk, which I'm now going to give. And let me just share my screen. And the topic of this particular talk is going to be how we manage psychological distress in times of stress, the stress of COVID-19 and all that. And I'm talking about that because this really is a way of me talking about a body of work that I've been focusing on for decades now. And I think to make it more relevant to people, I'd like to talk about it in the context of the pandemic, because we've been doing a lot of work in that space and a lot of other people have as well. And it's something that is of primary interest to a lot of people globally, as well as here in Australia. What I like to do is talk about mental health issues after adversity, talk a bit about the COVID-19 and climate change in particular, because they're probably 2 of the biggest challenges that I think we're facing at the moment and the impact they're having on mental health. How do we boost resilience in the wake of these adversities, and what are the future challenges that are really facing us at the moment? Before I get on to how things are changing, let me just give you a snapshot of sort of the prevalence of mental disorders around the world. When we talk about a mental disorder, I mean, it covers many, many different types, but the most common are without doubt anxiety and depression. And basically about 1 in 8 people have a mental health or a substance abuse disorder. And that's a lot of people. And what a lot of people don't realize is that mental health disorders actually represent amongst the highest burdens of disease globally. It's estimated that they cost about $1.15 trillion a year. Now, I can't even imagine how much money that is, but it sounds a lot. But recently, the Australian Productivity Commission actually put a dollar amount on what it's costing Australia. And it's estimated that mental disorders are costing Australia $200 billion a year. And that's in terms of health costs, it's in terms of lost productivity. There's a lot of direct and indirect costs that we pay for these mental disorders. Now, it's interesting when we look at this globally, because the prevalence of mental disorders is actually not distributed the same. And one of the great curiosities that's always been in the literature and no one's really been able to explain it wonderfully well, is the higher income countries have the highest rates of mental disorders, which is a little counterintuitive because we nearly expect those countries to have better health resources, be better protected against lack of economic challenges, etc. But one particular interesting study actually found that in terms of the prevalence of mental disorders, you could actually see the US as the epicenter, and then moving away from the epicenter, then rates decreased the further away from the US that you got. Now, I'll leave all jokes aside about US politics and US culture. I'll let you make your own interpretations of those, but it is an interesting sort of phenomenon, and probably due to cultural factors and mental health awareness in terms of how we measure mental health, rather than simply the presence of mental health disorders themselves. One of the questions that's often been asked is that, and we often read in the literature, or rather in the media, that mental health disorders are getting worse over time and that we as societies are becoming less resilient. But if you look over the last 30 years, the data is actually not suggesting that. It does seem to be somewhat stable over time, if we look over decades of time. Despite that, the amount of disability that's associated with mental health problems does seem to be on the increase across countries. And we measure disability typically in the context of what we call a DALY, which essentially translates to the amount of lost functioning or disability that's attributed to a particular disease. And you can see there in this PowerPoint that it is significantly increased over the last 30 years. And that does account for an enormous amount of economic loss. Now, one of the things we do need to be aware of, though, in terms of disparity around the world, and in terms of climate change. And of course, in Glasgow, climate has been on everybody's front of mind. This is a rather dated PowerPoint now from 2013. It just sort of highlights just a few of the key disasters that have happened worldwide. And in that year alone, there were 22 million people who were newly displaced as a result of disasters. Now that's a phenomenal number of people. And this is actually just occurring every single year. And most disasters are so prevalent in most parts of the world, drought being the most common one, that it doesn't even get reported. But in terms of a downstream effect of climate change, what we're seeing, and there's some interesting modeling coming out, very huge mental health impacts related to climate change. Secondary to either drought, storms, and other severe weather events. Now in Australia, we're used to this obviously on a seasonal basis. Bushfires are just part of our agenda, and obviously that's still fresh in everybody's mind since the 2019-20 season that seemed to go on forever and really affected huge parts of Australia. Just to give you a sense of sort of the extent of the mental health effects, this is a study that we did after the Black Saturday fires. You'll probably remember those back from 2009, so over 10 years ago now. We did a series of epidemiological studies across high exposed, medium exposed, and low exposed communities in Victoria. And you can see there that the rates of, this is post-traumatic stress disorder, the rates of PTSD were coming down over time. But even a decade after those fires in the highly affected regions, we still had about 17% of people still experiencing PTSD. Now, At any one time, if we look at the national rates of PTSD in Australia, they come in at about 4%. So these people are sort of experiencing the rates 4 times the national average a decade after the event. And this really underscores that these events just aren't discrete events. They do have a very long-term lingering impact on people and on communities. Now, the other major disaster that's been happening in recent times has been the refugee crisis. It's, to be honest, in terms of people's attention, it's sort of taken second place now to the pandemic. But for many years, particularly after the Syrian war, it was a huge, huge issue. Now, at the moment, we have actually over 80 million people displaced due to conflict or persecution. And that includes about more than 25 million registered refugees. And there's probably just as many non-registered refugees. And this is the biggest number since World War II. And it's a major challenge. And what happens when we look at those countries in terms of the common mental disorders, in terms of those that are affected by violence? Again, we can see that relative to the global rates, the rates of PTSD, anxiety, and depression are about 4 times higher in countries that have been affected by either violence or a humanitarian crisis, which does sort of highlight that it's not necessarily a level playing field. These countries that, to be honest, have no health system and are the least capable of dealing with mental health, they're the ones that are very commonly affected. And similarly, when we look at their burden of disease, because they don't have the health systems in place, and because they're often economically disadvantaged to begin with, the level of disability associated with their disorders are often proportionally higher than better resource countries. And so you can see there, for example, North Africa and the Middle East, highly disadvantaged and highly affected by conflict, and so greater disability. So the pandemic. Now everybody here knows what impact it has had globally. We've heard about it every single day of our lives for the last 2 years, mainly sort of through phenomenal epidemiological work that's gone on here and all over the world. And it's also had an unprecedented impact on mental health. I mean, I've been doing this work for nearly 30 years, and I have never seen such a flurry of mental health research. There have been hundreds and hundreds of studies done, including many cohort studies that actually commenced before the pandemic and then were measuring people's mental health during the pandemic. So we've actually learned a phenomenal amount in a short period of time. And really the studies that we need to look at the most are those of the cohort studies, those that actually looked at people's mental health in population surveys prior to 2020, and then kept looking at it during the pandemic. And what you're seeing here is a summary of a meta-analysis of about, I think it's 36 studies done around the world. So including many, many patients. And we can see here that the jump in PTSD, in anxiety and in depression are huge. In anxiety, we're up to about 25% of people in countries now reporting anxiety symptoms, and that's up from about 9%, and over 20% of depression. Now, these are more than double what it was before the pandemic, and it just translates to a huge number of people. And it's not affecting everybody the same. This is another review of many, many studies. And what we're seeing there in terms of the top panel A, that's referring to depression, and the bottom B is referring to anxiety. And you can see there that in the lighter color, that's the increase during the pandemic. And you can see that the rates are markedly higher. But you can see that it's much markedly higher in females than in males. Now, we know this across all anxiety and depression. Females are far more likely at risk. But during the pandemic, they've really borne the brunt of the mental health surges. Now, that makes sense because they're naturally more vulnerable. And I won't go into the reasons for that. It's a combination of hormonal and other factors, which is why we think women are more at risk. But also environmentally, they've often had to deal with more during the pandemic in terms of parenting, in terms of homeschooling, taking an economic brunt of the pandemic. But you can also see the shift there towards younger people. It's younger people and young adults. They've been far more at risk of mental health problems than older people. And again, we know that the older, the age group of like 15 to 25, they're always the most risk of developing a mental health problem. And this is partly for hormonal reasons and partly because young adults are going through important transitional periods in their lives. And so that's when we see virtually all disorders starting to emerge in that time frame. But again, during the pandemic, they've been particularly vulnerable to things like career interruption, academic interruption, relationship interruption. They're vulnerable to the effects of social isolation a lot more than older people. And also older people generally have more economically protected. So casual workers, etc., they're more at risk and they tend to be often the younger people. So a lot of the modelling is most concerned about, younger ones and females. And it's interesting when we look globally, it's a very, very linear relationship between the rise in mental health problems and the number of infections in a particular country, and also the timing of when there are lockdowns. Whenever we can sort of see those happening, the mental health problems go up. And I think we do need to remind ourselves that as much as we've sort of complained about lockdowns, etc., and sort of being a fortress in Australia, our infection rate and death rate has actually been very, very low relative to what many other countries have dealt with, that have actually led to far different and far worse mental health problems. And so when we look at the disability index, we can also see that during the pandemic, which is like the, what is that, sort of purple and sort of orange colours in the middle, we can see there that with anxiety and disorder, this is the increase in disability that's occurred. And you can see again, it's mainly the females that are driving that. But there's a lot more mental health disabilities since the pandemic. So to summarise, anxiety and depression's increased enormously. About 1 in 4 people have got these problems. I didn't mention before, but about 1 in 10 are feeling suicidal. It's interesting, though, that at the beginning of the pandemic, there was a lot of modelling coming out predicting that we were going to have a tsunami of suicides. In fact, suicide rates have not gone up by and large around the world. And in Australia, they've come down a bit. So it's interesting that some of the predictions have not panned out. But in terms of the general increases and in terms of modelling globally, it is estimated that we have about an estimated 53 million more cases of depression and about 76 million more cases of anxiety, which is just mind-boggling. And we are seeing this play out in Australia. So on multiple days in this year, in the latter part of this year, Lifeline, which has been operating in Australia now for nearly 60 years, has had its busiest days ever on record. It keeps breaking its daily record of crisis calls. And before I move on, I should just say that a lot of people are thinking that when restrictions end and we sort of get to this 90-95% vaccination rate, we're going to sort of flick a switch and everyone's going to be feeling better and the mental health problems are going to ease. There's good reason to think that's not the case. If we look back at things like SARS and previous pandemics that were nowhere near as intense as what we're seeing in COVID-19, we saw that many people who developed these problems in those pandemics, they continued in an ongoing way for years later. But it's also interesting when we look at countries who are ahead of Australia in terms of their vaccination rate and when they've opened up their countries a bit. It's fair to say that when the restrictions have eased, the mental health problems have also alleviated, but they've still very, very high, and they're much higher than they were pre-COVID. And so people are still feeling very lonely and there's still a lot of anxiety and depression. And so I think the bottom line there is that, you know, we have to be preparing for how we are going to deal with the mental health effects of the pandemic in the long term, because these effects are going to be felt by people, you know, for years to come. So what do we advise agencies about how to deal with these mental health effects, and particularly those countries that have got limited resources? And most of the world does have limited resources when it comes to mental health. And particularly when they're having to deal with hundreds of thousands or even millions of people who have actually got a problem. Now, the sort of committees I sit on and the meetings I'm in, we sort of tend to get asked these sort of questions. When we're sort of making policy decisions, should we be just helping everybody who is distressed? Or if the resources don't go that far, should we be helping everybody with a mental disorder? Or should we be helping everybody with just a very severe mental disorder? Or if we want to make it even more refined because our resources are so stretched, do we just focus on those very, very urgent priority ones like psychosis and suicide? Or do we just try to help everybody who seeks help? And to be honest, the answer to these questions is often just driven by what resources any system has available. And some people answer it differently. Some people say, well, let's just resource some clinics or centres exceptionally well, and we can just help people in a few communities. And so we can actually go like narrow and deep, and we can sort of treat them very well and in a sense nearly cure them. Others take a more public health approach and say, no, we should be spreading our resources more thinly so we can offer the most help to the most people. And it sort of results in then how does one set priorities? And let me say that we often sort of think about these sort of decision points. You've got the high resource countries and the poorly resourced countries, low and middle income countries. But it's not that straightforward, because we even have these divisions in Australia. So once we get to regional and remote Australia, for example, they are not well resourced. They have very few mental health specialists, and the extent to which their mental health problems are addressed is not really that dealt with like it is if you're in a major metropolitan centre. Now, the way we deliver mental health interventions, and particularly psychological ones, because I should say that when we're talking about these common mental health problems, such as anxiety and depression, very often the interventions, the evidence tells us, the interventions that have the most efficacy are psychological ones rather than pharmacological ones. There are exceptions to that, but that's a fair generalization. But the problem with these traditional psychological interventions that have been developed and trialed and implemented in the West, the problem is they are disorder specific. So we've got one for each disorder, be it depression, substance abuse, post-traumatic stress disorder, social phobia, generalized anxiety disorder, agoraphobia. I could go on and on and on. You know, we have many, many of them. And that's a real challenge in a lot of societies, because a lot of societies can't train people. They don't have those resources to train people in all these different treatment sort of protocols. Also, our typical treatments are very lengthy. They usually go for well over 10 sessions, and that's very costly for a health system that's stretched. And they often rely on complex and intensive strategies. That means training people and getting them qualified and upskilled is a real challenge. And so that means that who can deliver it is typically provided by disqualified practitioners. And this is a real challenge, because, as I'll probably keep mentioning, in low and middle income countries, for example, they just don't have those practitioners. I know psychiatrists, for example, in certain countries, and their catchment area, they're responsible for over 1 million people. You know, one psychiatrist. And so when they go and, you know, a typical day is they might be assessing and prescribing somebody a treatment, typically a pharmacological one, and they might see 60 patients in a day, because that's what they need to get through. Now, that would be sort of unheard of in Australia, but that's what many countries have to deal with. So we can't just be, you know, relying on these few practitioners to deal with a countrywide problem. But also, a lot of these countries simply just don't have health budgets. They can't often just, you know, cover basic things like cardiovascular, cancer, and other sort of diseases. And often mental health is really down the bottom of the list of priorities. And these factors really explain why in most low and middle income countries, these sort of approaches to deal with mental health just are not implemented. And this is why recent studies have sort of looked at this issue, and there is a huge treatment gap in low and middle income countries because they lack the mental health specialists. It's estimated that about 93% of people in these countries, and let's remember, low and middle income countries represent the vast majority of the world, but over 90% don't get treatment. And in terms of how the disparity in terms of how countries devote resources to mental health, high-income countries, we can put about $50 per person per capita. In low-income countries, it averages $2 per person. And I think that's a stark sort of contrast in terms of the amount of resources that can be allocated. This has sort of led globally in recent years to an approach that is very different from what's typically done in Australia, where we offer the very traditional medical clinical model. And the goal here is to really come up with feasible, affordable, and cost-effective interventions that can be implemented on a very large scale. This is particularly in low and middle income countries in which health systems are incredibly stretched and they've got very, very few resources. And this has always been the case, but it was really been exacerbated by COVID-19 because during the pandemic, these countries, because they're not getting vaccines, their COVID rates have gone up a lot, and economically they're suffering. Death is very frequent, so their mental health problems are going through the roof. So this is sort of the choice that policymakers have. We can either go with conventional psychological interventions that are done by specialists. There's typically a treatment protocol per disorder. It's often involving many sessions. It often requires a diagnostic assessment, which involves a whole new set of skills about having personnel who can make those diagnostic decisions. In contrast, a more public health approach takes a more innovative approach where we're not using specialists, but rather we're using lay people, non-specialists, who can be trained to actually deliver the intervention. We only have one treatment. So we only have a what we call the transdiagnostic approach that can address the modal sort of problems that people have. And this gets us away from having to require an assessment, a diagnostic assessment. We've got to have fewer sessions because countries like this can't afford to fund something that's lengthy. And also, people can't attend. They can't do these sort of sessions because if you're in the back blocks of Indonesia or Africa, the problem is that if a man has a choice between going into the field and possibly getting some work and feeding his family that night, or coming to a group session of getting some intervention, it's a no-brainer what he's going to pick. He cannot, afford to not earn a bit of money. So we have to make these as brief as possible to make it easy for people. And the focus has to be on self-management skills, because these people are going to have continuing ongoing stresses to do with either disasters, climate change, conflict, or just poverty. And so it's how we teach them to deal with that. So as I said, there's been a major shift in recent years in bringing lay helpers on board. And it's actually worked quite well. They typically don't get a lot of training. It's typically around a week of training. But a recent meta-analysis tells us that we can actually reduce anxiety and depression with a moderate effect size. And so it really is playing an important role in how a lot of these countries can actually alleviate common mental disorders. Now, this has led the World Health Organization to initiate a range of what they call scalable psychological interventions, with their goal of trying to reduce the treatment gap that we have globally and to improve access to effective care for people. And what the WHO is doing at the moment, and this is a rather recent initiative, is their goal is not to implement programs unless they've actually been independently tested through controlled trials, minimally in 2 separate countries or sites. And this is actually a huge shift for the WHO, because in terms of mental health, it's implemented things very globally for many, many years, which means countries all over the world are taking them up. And unfortunately, this has actually involved huge amounts of money, incredible numbers of resources being devoted to programs that, to be honest, are probably quite useless. But now they're sort of trying to take a much more evidence-based approach, which seems to be hopefully going in the right direction. So a few years ago, my team at UNSW, we worked with WHO to develop a program that we called Problem Management Plus. And it was meant to sort of tick all the boxes in terms of providing a scalable intervention that we could roll out to people affected by adversity. And what we did was we did a very big look, try to find out what were the best interventions that could actually have the best bang for the buck in terms of reducing problems people commonly have if they've got anxiety or depression. But it also had to be simple enough to be delivered by local lay providers. Now, in essence, we came up with 4 simple strategies, teaching people how to manage their anxiety through simply slowing their breathing down. And this actually has a long tradition of symptom relief. Just people who are anxious breathe too fast. I won't go into all the biological problems that causes. Teaching people how to solve problems, how to actually identify a controllable problem and how to break it down and to come up with solvable steps. Behavioral activation, making sure that people are maintaining productive routines is a very important way to actually ward off depressed mood, and accessing social supports is again been incredibly critical for good mental health. Now, I really want to emphasize that when we do these things, it's actually based on fundamental science. And let me take social support as an example. With all of the programs we try to build into these scalable interventions, we figure the best way we can do it is getting down to the basic science of it and working out how do we get it down to the simplest ingredient so that we can package this into a program, train it to people who are not educated, and they can deliver it to others. And I think social support's a good example of this because it's a very hardwired coping mechanism that actually exists even across species. And we've been doing a lot of work in this area, just to give you a sense of sort of how we build up these platforms. I mean, in the laboratory, for example, we might, we bring people in, we get them to give us saliva, we measure their stress hormones like cortisol and noradrenaline. We stress them in the lab. The way we stress them as psychologists, we simply just dunk their whole arm into icy cold water, which is a very solid way of actually inducing an arousal response. And then we simply present them randomly with either representations of their attachment figures, their social supports, like a romantic partner, or just another person who just happens to be somebody else in their network who they don't really know. And then we sort of measure their stress responses later. And what we find is that people who actually are just given that very momentary reminder of a social support, they have a markedly reduced stress response hormonally. And we've seen this across many indicators, across parasympathetic response, across capacity to sort of limit encoding of trauma memories, on many, many indicators. We've also looked at this in the field. I think an interesting study we did a number of years ago, a colleague of mine started a study after the Ash Wednesday fires. Now, those of you who can remember back that far, this is a very, very big bushfire that happened back in 1983 outside Adelaide. And what he did was he assessed the parents of 8-year-olds at the time on a number of parameters. And what we did recently is we went back 30 years later and assessed those kids again. And we assessed them for PTSD, but we also assessed them for the extent to which they had a particular attachment security tendency. And that is their ability to sort of rely on other people and engage in social supports with others. This isn't a very friendly graph, but essentially what it tells us is that on the day of that fire, because it was a school day, it was totally by chance whether parents were with their child or not. And about half the kids were actually separated from their parents. And what we found was that the kids who were separated from their parents during these fires that were really life-threatening, they were terrible fires, 30 years later, that actually led to these kids having a very avoidant attachment tendency. And that means they just don't access social supports. And what that led to was worse PTSD 30 years later, which just highlights that even on a single day, it's a life-threatening event. If I'm taken away from my social support, it can actually have a long-term impact on my capacity to engage with others and on my mental health. We've also noticed this in other work we've done. So we've done work, for example, using social network analysis. Now, what social network analysis does is it's an interesting approach where rather than most of the work psychologists do is we look at individuals, like their mental health. But social network analysis is something that comes more out of business, to be honest. And it looks at relationships between people. It could be a football club, it could be a church, it could be a whole big organization. And it looks at the extent to which people are connected, to which they're relating to each other. So people can have close ties or distant ties. And this is the sort of figure that you end up with in a social network analysis. So if I did a social network analysis of the Royal Society of New South Wales, I'd probably find there are some people who are highly central and are connected to lots of other people, and there'd be other people who are very distant and only connected to a few, and others are just totally not connected to any. Well, after the Black Saturday fires in Victoria, we did the normal epidemiological studies. Sorry, I referred to these earlier. And what we also did, though, is we did a social network analysis. And we actually found out, we asked everybody, tell me 10 people who you relate to, who you're close to. And because these were all in regional towns, everybody sort of knew each other. So we actually could then do a social mapping exercise and worked out who knew who was connected to who. And what you would expect is that we have found, many people who are highly connected, some people who are mildly connected, and some people who are totally, not connected at all. But the interesting thing about it is that we assessed everyone's mental health. So we could actually relate their connectedness with their mental health outcomes. And I'm not going to go through this in detail, but essentially what it tells us, I think the most important slide row here is the second bottom one. People were more likely to develop PTSD if they knew people, they were part of a social network, but the people they knew did not know each other. That is, the social network they were part of was very fragmented. Now, if people were part of a united social network so that the people they knew also knew each other, that indicates a social network that's well functioning. That actually reduced the rates of me having PTSD. And this is sort of an important sort of avenue to sort of understand how we respond after a disaster. And it sort of is more evidence for why in building these scalable programs, we want to emphasize social support. So that was a bit of a digression. Let me get back to the interventions. So this was the Problem Management Plus we developed with the WHO. It's been developed as a manual. It's freely available globally now, and WHO being WHO, it's everybody around the world now is using it. And we've done it in multiple RCTs, randomized controlled trials around the world. Just to give you an example of a couple of them, the first study we did was one made by a colleague in Pakistan. This was in an area called Peshawar, which is sort of on the border with Afghanistan. It's a very rough neighborhood. A lot of terrorist activities there, a lot of disasters. In this study, we randomized about 340 people to either PM plus or they got treatment as usual, which was like referral to local services. And then we followed people up 3 months later. And essentially what this program told us was that 3 months later, the people who got the PM plus, and this was actually delivered by lay providers, I should say, after getting 8 days of training. They had markedly less anxiety and markedly less depression. We then did a subsequent one in Kenya, in a neighborhood where gender-based violence against women was very, very high. And it was interesting here because the people we trained basically had a year 10 level education. And again, we randomized about 400 people. And again, in terms of their psychological distress at 3-month follow-up, they were markedly doing better if they got the PM plus. I'm going to skip that one. And also the implementation angle. I mean, one of the problems whenever we see all these trials in the literature, people often publish these in great journals like Lancet and JAMA. But then if you go back to those sites 10 years later, you can see that nothing's actually changed in the country where they've done them. And that's what some of the things we were trying to really do here with the WHO is change that so that no one really does a trial unless you really set things up so that you can implement it in the country, in the local health system after you've done the trial. So we actually, after doing our trial in Nairobi, worked with the local Ministry of Health, and they ended up training 700 odd local volunteers, gave them all the set training, and then they gave PM Plus to, in the 12 months after our trial, to about 3,600 people who were screened to stress in Nairobi. And what more, we actually got them to start doing assessments of everybody. And what we found was that, of course, this wasn't an RCT because this was an implementation trial. The people, who were getting the PM Plus were doing markedly better markedly reduced on depression and also on disability. This was my latest endeavour. This is the place where I've just done my last study of PM Plus. It's a refugee camp on the Syrian border, and at the beginning of the Syrian war, this didn't exist. It was just desert, and then over a few months, it became the 4th largest city in Jordan, where they had an influx of refugees. Since then, they've divided this camp into 2 separate camps. And in one of those, we did this trial of PM Plus. And again, it was just using local people. We trained them for 8 days. And again, we found that at 3-month follow-up, wasn't a strong effect. And I must say, it was a horrible trial to do because we did it during COVID, when the lockdowns in this particular camp were severe as the virus spread. But we still got reduced depression in people who got the PM Plus. So even under those very, very harsh conditions of a population that was highly exposed to torture and war, and then suffering from the pandemic, it still seemed to do some good. And then it brings us to the pandemic. So what we've done since the pandemic is we've adapted our program to the needs of people, distressed by not just infections, etc., but, and this was more the case in Australia, the problems of lockdown, unemployment, and things like this. And we extended it from 5 sessions, which it was initially with PM Plus, to 6 sessions. And we ran it as small groups, 4 people in a group, and we did it via video conferencing. And we did that obviously because it was done during social, lockdowns. It also meant that we could do it across Australia, and particularly in remote and regional Australia, that often gets left out of this sort of work. And the reason we had to adapt it a bit was that there were specific issues that were cropping up in the pandemic in terms of worry that PM Plus did not deal with exceptionally well. And obviously in things like trying to get people to sort of maintain their usual routine, being behavioural active and accessing social supports, not easy to do in the middle of a pandemic when everything's locked down. So we had to sort of adjust things accordingly, to sort of teach people about how to overcome those obstacles in order to be able to deal with those problems. So we've done a few trials now, but one we've actually got data on I can share with you. The first one we randomised 240 people across Australia to either coping with COVID, which was this adapted PM Plus, or to a self-help program where we actually gave them the same skills, but they were given it to them we emailed it to them and they could sort of work through it in a self-paced manner. And basically it worked very well. So the people who got the coping with COVID, at 6 months later, they had markedly less depression and markedly less anxiety. And so, we're continuing on. We're doing more trials now. We're collaborating with, I'm part of an EU consortium. And so we're sort of doing these trials in Spain, Italy, Netherlands, and some other countries in Europe that are particularly had it rough, and now going through 4th or 5th waves as they enter winter. We've adapted it and just done a trial in Switzerland for healthcare workers. Don't have those results yet. And we're just starting another one in India at the moment, to see how we can sort of tested in sort of more of a low and middle income country. And that's one of the big issues that we do need to deal with, because they are the ones, like with vaccines, tend to get left out of this equation. So we are really needing to sort of develop programs. I would say that one of the great challenges in terms of moving forward with these scalable interventions, and I think this is really highlighted by the pandemic, is that the data I've showed you tells you how wonderful they are in terms of reducing the baseline levels, but it doesn't really highlight the number of people who don't respond. And it's fair to say that across these different trials, 30 to 40 to 50% of people still have a disorder after it. Now, that's not surprising when we consider these populations and when we consider all they're doing is getting 5 sessions of an intervention, which, to be honest, is rather light touch. And similarly with the COVID programs, if we're dealing with the many of the populations in India or in Europe, given the death rates there and the nature of the medical sort of situation, the rates of more severe disorders such as prolonged grief disorder and post-traumatic stress disorder are very high. And we really haven't really sort of adapted these programs to develop those, to target those. And that's one of the great challenges we do have. And one of the programs, actually, I'm just about to start a new trial in Jordan, and it's more of a step care program. So we're really starting off with one of these sort of light touch interventions. And then for people who don't respond, trying to scale it up to address the people who have then got that persistent problem. Because there's always going to be people who don't respond, and particularly in these populations, and we do need to come up with scalable, affordable programs that can deal with their needs as well. Okay, that is the end of the talk, so I will stop there. And thanks for your attention. And let me finish again by thanking the Society for the chance to give this talk. And also, again, just for the great honour of receiving the James Cook Medal. It's deeply, deeply appreciated. Thank you.
Well, thank you, Richard. That was a very thought-provoking talk. So I've really got just a few questions to ask you, and I hope it stimulates some further discussion between us. It occurred to me when you were talking about the scalable interventions, this is a promising approach, but I wondered how different that is to the existing lifeline approaches to supporting people and perhaps beyond blue. Could you elaborate what you're doing that might be different, or how they might fit with the model that you're proposing?
That's a good question. In essence, I guess what a lot of the other services that are available are essentially crisis lines. Yeah. So, I mean, Lifeline's been doing this wonderfully for nearly 60 years.
I heard, yeah, amazing.
Yeah, and you know, it's when people are suicidal and in crisis and need to talk to someone urgently. What it doesn't necessarily do is offer therapy or treatment or management of a problem. So I think what we're trying to do here in the scalable interventions is teach people strategies that it's actually not just getting through that moment, which is really what Lifeline does, but it's more about trying to teach people strategies to, you know, actually deal with the cause of the problem. And it's, if you like, it's a halfway point between then traditional therapy, which is like doing it very intensely, but it actually takes a longer period of time with a specialist, etc. It's more of a halfway ground, if you like, between traditional therapy and the sort of crisis management that something like Lifeline would do.
Mm. So I think the example you gave in your talk is about someone who was quite distant away from help. So it made me think, is there a role for social media, something in providing that sort of ongoing, not just crisis management, but something that has a longer lifetime support?
Well, models are moving towards that. realizing that any intervention that you give, I mean, to be honest, the best example is like the vaccine, as we're all doing now. We got our jabs, but it's only good for so long, and then we've got to get boosters, and we have to do that to keep our immune system up. Psychologically, it's a bit the same. As humans, we tend to forget things. We tend to forget good practice, good strategies. So where models are now looking at, we're trying to do some trials at the moment in this regard, doing more step care, for example, where we're providing these sort of low scalable interventions, the low intensity ones, and then if people aren't responding, we sort of upgrade them, if you like, to more intensive ones. Now that's happens in all areas of medicine, tends not to happen in this scalable intervention space so much. But also we're doing it by trying to augment these scalable interventions by developing apps, for example. And most people around the world now have access to an app, or at least to the internet. And so if they can actually have a toolkit of things that are constantly available on these apps, and hopefully the way technology is working is we can start to individualize these things more, so to tailor to a person's needs when they need them. Because at a certain point of time after doing one of these interventions, they might be doing fine. But then when their wife leaves them, or they lose their job, or something happens, 6, 12 months down the track, they then need to get help. Having something accessible like an app that's instantly there and reminds them of basic strategies just might make a bit of a difference.
Good. So you actually also mentioned that in your talk that you've shown quite good success rates with people, but you mentioned the people you haven't been able to reach, the remainder, I think you called them. Have you sort of any strategies, things you're working on that might be able to reach those that don't seem to be reached by your current approach?
Well, that does speak to the step care that I just mentioned, in that, like if you think about the pandemic, for example, parts of Europe where I'm working, where the death rates have been huge, and when you sort of see what's happening in the ICUs there, I mean, the amount of traumatic stress, when those people who do survive, the level of trauma that they go through in the ICU, and what they're dealing with afterwards, and as well as the medical staff. But on top of that, the families of people who die, who probably a week earlier were doing fine. And the deaths tend to be rather traumatic because the people tend to be rushed into ICU. And it's the nature of the infection. People can't physically be with the person when they die. So usually it's just, they're saying goodbye to them literally on telephone. Now all that's very traumatic. And so that leaves the family pretty devastated afterwards. And so how you deal with things like PTSD and complicated grief, when you're on the scale that we're dealing with at the moment, we need more scalable ways to do that, particularly in the countries that just don't have the resources to deal with it. And those countries, we need to understand they don't have mental health systems, most of them. And whatever how stretched their health systems are, they're understandably all focused on the pandemic at the moment, and on transmission and dealing with people who are infected. Mental health comes right down the bottom of the list of priorities. So we do need to come up with ways that we can get down to the basic ingredients. We know how to treat these conditions, but we haven't really adapted them yet to these scalable ways. And that's something I'm working on with people overseas at the moment, to think about how we can actually do that. But we've got to evaluate it in trials, because there's no point rushing in and doing these things if we can't actually prove it.
So you touched on the pandemic. So what are your views on how Australia is managing mental health during the pandemic?
It's trying to do a good job. I mean, when I look at countries around the world, I think, to be honest, Australia at the moment, we actually have a Prime Minister and a Health Minister who are very pro-mental health. And they've been sort of, generous in sort of extending we have a system in Australia called the Better Access Scheme, where people can access mental health services, and they've extended this to like 20 sessions, which are rebated by Medicare. And they've extended this so that it can be done by video conferencing, and that one doesn't need to go and see somebody face to face. Problem is, need has outstripped supply. And because they've extended the sessions from 10 to 20, everybody's still seeing it, you know, all their mental health people, the psychologists, etc., and psychiatrists. And so it means nobody has time or space to see anybody else. So our big dilemma at the moment is trying to help people get to see anybody privately. And that's really where all mental health is delivered, most of it in from the anxiety and depression space at the moment. The public health system tends to deal more with the severe and acute end of mental health. But it's very hard to see anybody, and lots of people have closed their books because they can't see anybody else. So we do have a big problem in terms of accessing mental health in Australia. And the pandemic has just exacerbated this enormously. And I just can't see this problem improving a lot in the near future.
So looking perhaps a bit more positively, have there been any positive effects on mental health during the pandemic?
It's been one of the real curiosity. Yeah, it's been curious because at the beginning of the pandemic, it was all gloom and doom. And everybody thought that we were, you know, it was going to be sort of the Armageddon of mental health. Suicide hasn't increased around the world generally. Japan's been a bit of an exception, but over, you know, on average, it hasn't increased. In fact, Australia has actually decreased a little bit in terms of suicides. We'll have to see how things pan out in the long term. But there's also been other examples where rates of disorders have actually come down. A study our group did recently with Syrians who just fled the war and were sort of in a camp in Jordan, where we've been doing work, and the rates of PTSD actually came down. And you know, you've got to ask, why is this the case in some people? And it's a little bit when you've got this mental health problem pre-existing, and then you look around you, and then suddenly everybody else has to start living your kind of life. So nobody else is going out. Everybody else is sort of deprived socially. Everybody else is miserable. So we actually have theories in psychology, social comparison theory. So I view myself in comparison to everybody else. And everybody else is doing badly. Maybe I'm not doing that badly myself. And there's other factors to come into play. So there's probably some subgroups that are actually done better. And we certainly know there's a lot of people who have enjoyed lockdowns, to be honest, and are actually struggling and having to face going out into the real world again. And they're quite happy to sort of maintain this hermit of a lifestyle.
I'm feeling a bit like that myself.
Well, to be honest, it is a bit of a baby boomer phenomenon.
Yes. So is there differences between, you know, the first world and third world countries in this, you know, the incidents perhaps dropping of mental health, or is it more this a first world matter that we're saying, you know, we were all locked up here and we can't get out? So
I think how it's impacted on mental health is pretty, when we look at the world maps of just sort of how mental health has been impacted by the pandemic, you can see a pretty linear relationship between, you know, in like lockdowns and mental health going up, problems. And it's not, and to be honest, in the third world, lower middle income countries, it's not so much for the same reasons. So for us, it's very much people are socially isolated, so they get lonely, and that sort of has direct impacts. But in the rest of the parts of the world, often a lockdown means starvation. So some countries I'm working in, they basically, you know, went into hard lockdown, but they nearly had more people dying from poverty and starvation because these people just couldn't get out to make some money to eat. And so they had to rethink those policies and think, well, no, we're better off just, you know, tolerating, you know, rising infection, so at least people can eat. And that's sort of the, we don't have to deal with those sort of metrics in Australia. But that's really what they needed to deal with in a lot of those parts of the world.
So one of speaking of sort of metrics, do you ever measure something such as resilience, for instance? Would you see resilience improving under these circumstances? Is this perhaps a positive factor?
Well, a lot of people, have been looking at these sorts of things, and even, resilience is defined as generally as being able to bounce back after adversity.
Mm-hmm.
Other people even talk about growth, so they even sort of grow out of this. And of course, there's reports coming out of both. And for me, I think what it says is that it's a mistake in the pandemic to just make generalizations about everybody.
Yeah.
We're all different. And, anybody who studied statistics understands the error of actually looking at the average or the mean. It's always problematic. We've had very, very different trajectories according to different subgroups of people. So, we know there are certain groups that are faring very, very well, and particularly those that are financially protected, those who are socially supported, etc. But we know the younger people, we know the unemployed or the underemployed, people in the gig economy, the casual workers have suffered. There's all these various other factors that come into play that do really impact on some people being more vulnerable. But those other, the converse of those factors actually means other people are more resilient, and they're actually sort of coped quite well. And even the way we're talking now, obviously remotely, clearly that is a potential positive that's come out of this. On one hand, we're all tired of it. We'd love to be all standing around in a group talking, because there is a benefit in that probably can't be replaced. But it has facilitated an enormous amount of communication and rapid organization and deployment of things during the pandemic that we wouldn't have thought possible 2 years ago. And that occurs in mental health as well. The way we do therapy now has totally changed, and a lot of us wonder, will we ever go back to the traditional face-to-face? And it'll be a hybrid of that probably going forward, because a lot of people prefer it. We can reach out to regional and remote Australia in ways that you just cannot. They don't have specialists out there, so it
don't even have a lot of ordinary GPs. So yes,
exactly.
Yes. So that segues to my next question about what you might see are the biggest challenges ahead in both mental health in both Australia and perhaps internationally. And as you said, it probably varies from area to area. But
yeah, I think in Australia, it's even the best treatments we've got for our common mental disorders, like anxiety and depression, if we're totally honest with ourselves, probably 50 to 60% of people are actually responding to our best treatments. That's always been the case. And to be honest, over 30, 40 years, we haven't improved on that enormously. A lot of work being done in this area, and we do need to really try to sort of come up with other ways to improve on that. And one of the things is psychiatry and psychology has not done well, where obviously other areas of medicine, cancer is probably a great example, where it's far more personalized. If you have a certain typology of a certain disease, you get targeted towards a certain treatment. We tend to have a one size fits all. And then if you have a particular diagnosis, this is what you get given. And then it's trial and error. And see whether you respond to it or not. And if that doesn't work, let's try drug B or drug C. I think we need to move towards a more personalized approach, so we can actually understand that these are the different subtypes of problems that people have, and what's the best evidence for treating those. We've got to get up to 70-80% response rates if we can. And that's one problem we've got locally, and the other one is just the treatment gap. There's a lot of people not getting help, definitely all over Australia, but most in remote and regional. And there's been a lot of commentary about that lately. And it's not just the pandemic, it's just drought, it's economic downturn, it's those sort of factors that it wreaks havoc. And I mean, these same issues apply in low and middle income countries, but not, you can magnify that enormously because they don't have the resources. I mean, in high income countries, we tend to spend $50 a person on mental health. In low middle income countries, it tends to be $2 a person. And that's, they don't have the resources and they've got phenomenal numbers of people. So we've got to think about, there's no point talking about great programs and wonderful ways we have of, treating disorders in those countries if we don't come up with them in a way that we can sell it to a government and saying, not only is this affordable, but this is actually cost beneficial. And that's where there's been great work done, showing that by having these scalable interventions and actually treating these disorders and investing a small amount, there's a huge dollar return in terms of improved productivity. And that's really what sways governments, particularly in low income countries, to think, well, this can actually help us in the bottom line. Because they have to work out what their priorities are with very limited resources. And mental health is a huge drain on countries' productivity. And a lot of countries haven't caught up on that yet.
And probably not so obvious, I suppose, as a lot of physical ill health. Yeah.
Exactly.
Yeah. Well, that actually probably takes us full circle to your topic about, the positive, hopefully the positive effect of these scalable interventions. So I do thank you for
thanks.
Congratulations on having the medal, the James Cook, and for giving your talk to support that. So I think it was a really, as I said, thought-provoking talk, and the questions I've found very interesting. So before we wind up, I'd also like to thank you or congratulate you for your Premier's Science Prize, which you're probably getting at this very moment somewhere else. But we couldn't be live. We had to be recorded because you're in so much demand. So.
Yeah, thanks a lot. Sorry I couldn't be there in person, but I know nobody's in person, so that doesn't make me feel
No, we've been doing this Zoom for a couple of years, actually. So
yeah.
Thank you very much.
My pleasure, and thanks
Once
again.
Great.
Okay.
Thank you. Bye-bye.
Bye-bye.
Thank you. Thank you so much, Richard and Liz, for this extraordinary, well, I think, to me, it's also exciting that, by science, you are being into this, well, I think of the wow factor is PM+. PM+, I always remember PM+. But how to take psychological services out into areas of underprivilege where there are so few practitioners and so on. I think it's just extraordinarily wonderful. That also the fact that you verify it by randomized trials and so on. Look, it's all been great. Thank you so much, Richard. Thank you so much, Liz, for your intelligent question of all of this. And thank you, everyone who is listening. Thank you and good night.